I think we can go ahead and get started. I have the pleasure today of introducing Dr. Silverstein, who is our current clinical neurophysiology fellow. She completed her undergrad degree at the University of Missouri. Following that, she obtained a Master's of Science at Lincoln Memorial University. And then after that, did a combined DO and Master's of Business Administration, also at Lincoln Memorial DeVos College of Osteopathic Medicine, before matching into child neurology at Phoenix Children's, where she completed her 5-year child neurology training and served as our chief resident. And then we were lucky enough to coax her to join our clinical neurophysiology program. And she is our inaugural fellow in the CMP fellowship, where she has been doing a wonderful job and working on several projects, including looking at time to treatment and status epilepticus. And today she is going to talk with us about transition of care in pediatric epilepsy. So I'll hand it over to Dr. Silverstein.
Thank you, Dr. Fox. Good morning, everyone. So like she said, I'm going to be talking today about transition care for patients specifically with epilepsy. However, my hope is that even these fundamentals can apply to other patients outside of the spectrum of epilepsy. So hopefully can kind of take these concepts into how we administer care for our patients. So my objectives today, to identify the appropriate needs for transitioning patients with epilepsy, identify strengths and weaknesses in our current transition of care models for epilepsy patients, and then identify potential solutions for improving transition of care for epilepsy patients. And I do not have any disclosures. So what is the transition of care? So transition of care is a planned, coordinated movement from a child and family environment of pediatrics to a patient-centered adult care setting. There's a transfer of care, which basically just says transferring from pediatric to adult provider. But we really want to hone in on the transition process, which is a lot more complex and ideally well coordinated so that patients and their families do not have surprises, disconnections in their care, and it's a seamless process. It's a very challenging concept, not only for patients with epilepsy, but any children with various chronic illnesses, because there's not a lot of standards for how transition of care should occur, like what ages should we start talking about it, when should it occur, and of course it's very patient specific based on their different challenges or potentially comorbidities as well. So specifically some challenges in patients with epilepsy, while seizures do remit in a proportion of children in around 50%, seizures will persist into adulthood. There's kind of 3 different outcomes examples that I'd like to point out. You have well-controlled epilepsy in a cognitively normal patient, like for instance, like juvenile myoclonic epilepsies. So are difficult to treat epilepsy in cognitively normal patients, like a temporal lobe epilepsy, or you have intractable epilepsy and often is associated with cognitive delays. About 40% of patients that are considered chronic will require lifelong treatment. And then as our medical care advances, more children with epilepsy are surviving into adulthood. Outcomes with people for epilepsy have shown to be driven by lots of factors, including challenges in daily activities, attending school, maintaining social relationships, employment, transportation, independent living, and especially due to the risks of having a seizure. And I'm just making sure is anything going, any questions in the chat box? Okay, just checking. Additionally, epilepsy patients suffer from chronic comorbidities, anxiety, depression, developmental disorders, headaches, so other things that we also have to think about as providers that goes along into that transition process. Social factors and the illness of burden in epilepsy makes it more likely for people with epilepsy to require public assistance, with 1/3 of people in epilepsy in the United States being on Medicaid. So thinking about the chronic costs of medications, missing work to come to appointments is quite a lot on those patients and challenges that they face. And then there was a study by Dr. Thurman, with adults with active epilepsy were more likely to be insured under Medicaid and were less likely to be employed and more likely to be reported as disabled compared to adults without epilepsy. Patients with epilepsy also experience greater barriers to healthcare, such as inability to afford medications, access to mental health, and more likely to require transportation, especially if they have chronic or active seizures. You know, every state's driving law is different. For Arizona, it's 3 months seizure free before you can start driving again. So for a lot of our patients, they're not able to drive, and that limits their ability to get to work. And then these challenges also further manifest, especially among people of different socioeconomic backgrounds, race, and locality, where they are in relation to potentially resource-rich areas. So this was a nice article just kind of giving kind of a snapshot of some potential demographics of our patients. So this was epilepsy transition challenges for caring for adults with childhood onset seizures. So about 75% of children with symptomatic epilepsy survive at least 20 years after diagnosis. So like we said, we are getting better, which is a great thing. But also thinking about this, 70% of adults with a history of infantile spasms exhibit severe learning disabilities, and 90% of those patients have the same IQ as they did when they were 8 years of age. So obviously comes with lots of further challenges for those patients and comorbidities. Also, our patients, especially in the transition time, have the added risk of sudden unexpected death in SUDEP, or epilepsy patients, which is also called SUDEP. So this is for all of our patients. It has the annual incidence rate of about 0.81 in 100,000 for the general population, but with patients with epilepsy, it's about 1.16 cases per 1,000 patients with epilepsy. So not a low number. And then when you're comparing to the loss of years lost from SUDEP compared to any other neurological diseases, SUDEP ranks only second to stroke. And I'll kind of describe what that means here in a second. This was a study, again, by Thurman, reviewing cases from 4 different studies with a total of 228 cases of SUDEP that were reviewed, and kind of assessing the public health burden of SUDEP. So this was kind of the age range of all the cases of SUDEP that they looked at. And if you can see, a lot of our patients, the 11 to 20, 21 to 30, and 31 to 40, make up the highest burden for potential SUDEPs. And again, kind of pointing out that 21 to 30 age range is near when a lot of our patients are going through the transition process to adult care. So just keeping that in mind. And then, so again, like I said, it is not necessarily the #1 cause of death or #1 percentage of deaths. As you can see on chart A, it's about, in this chart, it's about 3,000 deaths compared to Alzheimer's, stroke, Parkinson's, ALS, MS, and meningitis encephalitis. But when you compare it to the years of potential life lost, meaning that if these patients were to have SUDEP at an early age, the potential life loss is much higher compared to all these other neurological diseases, only secondary to stroke. So they estimate a total of 100,510 years of potential life lost in the United States, and this was due to SUDEP in 2010. So it's a huge burden and potential risk for our patients. And then I just wanted to point out that kind of went a little bit further into what is your risk potentially based on the year that you, or what age range you started having seizures at, because this can increase your risk. So they calculated the risk of SUDEP separated by age of onset from age 1, age 15, and age of 30 years. They made the assumptions that epilepsy would not remit after diagnosis and would require lifelong treatment. And then the epilepsy onset at age 1 yielded a cumulative lifetime risk of SUDEP of 8% by age 70. Epilepsy at 15 years of age yielded a corresponding risk of 7.2% by age 70. And epilepsy at age 30 yielded a corresponding risk of 4.6%. So our patients here in the pediatric clinic who are potentially going on for lifelong treatment and in transitioning to the adult care have a huge risk for SUDEP. And so that burden is very high for our patients, and just something that I wanted to point out because that can't be unsaid with things that our patients have to deal with. This was also another case of SUDEP, so sudden unexpected death in epilepsy patient, kind of looking at the risk factors. This was a systematic review. They looked at several articles, and they assigned how they filtered out some of these articles. So they looked at articles that were looking at the quality and diagnosis of SUDEP. Low, they scored it from 1 to 10, low quality being a 1 and 10 being a high quality paper. And then anything below a 7 was eliminated for further analysis. And then they assigned it a risk factor ratio for potential risks. So they looked at every single paper, looked at the risks that they were trying to examine as potential risk for SUDEP, and then assigned it a ratio with a higher ratio for a stronger risk factor. And then there was 120 papers that were reviewed. Only 27 papers were included in the total study, which was a total of 900 cases of SUDEP. And these were 75 from Medline, 0 from Cochrane, and then 105 from MBase. And then here on the left-hand side, you can see why they might have eliminated some of those studies. Again, many of them being not analyzing risk factors for SUDEP or low-quality studies. And then they looked at the factors between all these papers, what people were studying, looking at demographics, young age, male sex, Black race, the type of epilepsy, whether generalized tonic-clonic seizures, high frequency, chronic epilepsy, early onset epilepsy, psychiatry, whether there was unusual recent life events, comorbidities such as psychiatric illnesses, alcohol abuse, therapies, if you have poor AED compliance, different particular uses of AEDs, or polypharmacy, and then circumstances of their death. Were they lying in bed? Were they sleeping, prone position, being in a bedroom, being outside the house? And then other were like hyponatremia and cardiovascular disease. And then again, they defined young age as less than 45 at the age of death, high frequency of greater than 1 seizure per month, and then chronic epilepsy is a duration of greater than 10 years, and then early onset of less than 45 years at diagnosis of epilepsy. And so they assigned everybody, or all these risk factors, a certain score, and they identified strong risk factors for SUDEP, again being young age, generalized tonic-clonic seizures, early onset, male sex, and then prone position were more of the highest potential risk factors for SUDEP. And just pointing out that those are a lot of our patients, early onset seizures and young age. So those include a lot of our patients. So again, just going into that, this is something that we have to, as providers, educate our patients on, and hopefully during the transition process, which we'll point out kind of some of the difficulties, make them aware of that of these issues, especially with SUDEP. So going into a little more, I just wanted to highlight kind of what our patients look like in terms of demographics, and who especially are going through the transition process, and what kind of things do they want to know. So this was a specific paper, it's a little older, are what people know about their epilepsy and what they want from an epilepsy service related. This is a paper out of London. It's a total of 70 patients. The age was a little older. Again, it was from 18 to 76, but I just kind of wanted to give you an idea of what kind of adult patients might be looking like, the patients that we transition, with the mean age of 41 years. Just wanting to point out the age of diagnosis of the majority of these patients were between 0 and 10 years of age, 48% of those people, and then another 23% between 11 and 20 years. So these are all of our patients who will then eventually go see adult providers. Also pointing out the frequency of seizures in these 70 patients, more than 1 seizure per week in 37% of patients. And then 1 week to 1 a month, another 18%. So these are patients with chronic epilepsy, potentially suboptimally controlled, who are in the adult healthcare system, who were probably seen in the pediatric system at some point. Also wanting to point out some of the other demographics, marital status, about 50% were single, another 10% divorced, so a lot of majority maybe on their own. And then this is an older study, but also wanting to point out that 55% of the patients that they interviewed were receiving at least one form of benefit, whether that's a disability benefit, income support, mobility allowance, so requiring extra assistance in their daily lives. And then they asked those patients kind of what they knew about their own epilepsy. So, and this probably is reflective of kind of, if you were to do this study again today, which we'll go in more, what our patients know about their epilepsy. So did the patients know the correct name for their seizures? 70% did, or 70% did not. So they couldn't even name the type of their seizures. Did they know the results of their EEG assessment? 75 could not give a description of their EEG, and only 12% were able to give a poor description. So the vast majority don't know what kind of seizures they have and what their EEG has said. Do they know the results of their brain scan? 65% said no. Patients did do well on knowing how many AEDs they were taking. The vast majority did know the names of their medications, 85%. Correct dosing of drugs was pretty good. 73% knew the correct dose for their medications. The frequency was good at 79%, but could they describe the purpose of their anti-epileptic medications? 55% could not. So again, that shows you kind of where maybe some barriers in patient knowledge exists, and I think that this is probably reflective if you were to do this study in any patient population. And then the table 6 on the right-hand side was asking kind of what they wanted from their providers. So the highest was advice or supporting counseling for patients and families, information on Social Security benefits, insurance and driving information, employment opportunities, how to stay safe in the home. Those are all things that we can, as providers, integrate into our discussions when we're with patients, seeing what kind of information that they need help with, especially if they're going through this transition process. How can we best set them up to be successful as they go into their adult years? So this is another article kind of going over the characteristics of patients, especially going through the transition process. So this is a little bit newer study. This is in 2022. This was an article from Transition to Pediatric to Adult Care Among Patients with Epilepsy. This was in Korea. So this was data was retrospectively collected from patients with epilepsy who are now 18 years or older who had visited this pediatric clinic between March 1990 and July 2019. So a pretty long period of time. Just kind of wanting to go over the demographics again. Some of these are not statistically significant, but I think give a representation of our patient demographics. So male to female between transition patients and non-transition patients were pretty similar. Age of onset of epilepsy, around 8 years of age for both. Other things I wanted to point out, number of AEDs since the last follow-up visit. Most of them were on 2 AEDs. And then, and again, like polypharmacy, so 61% of patients were on polypharmacy. So chronic epilepsy. Seizure frequency was a little better in these studies, more in the yearly or less than yearly category, so better control potentially. Some of these patients had gone on to have VNS, epilepsy surgery. Again, the non-transition patient groups was much higher than compared to the transition patients since implementation of this clinic. But just something I wanted to point out. And then, although patients recommended to transition to the adult clinic at the age of 18 to 20 years, only 39 patients had actually been transitioned through their clinic. So again, goes through the demographics of these patients. A lot of them had brain lesions, intellectual disability, and then psychological comorbidities such as depression, anxiety, ADHD, and schizophrenia, which again, I think represents, would be similar to our patients. So where are we in terms of how good are we at transition? So this was a study called Transition in Epilepsy, a pilot study with patients in and outside of academic centers. This was published in February 2024, so just last year, in the Epilepsy Behavior Journal. So this was a survey that was given to patients and caregivers at a patient support group meeting at the 2019 Epilepsy Awareness Day at Disneyland. So this was from patients from all over the country. Questions were designed to obtain the patients' and families' opinions on the following: how prepared they felt to move into the adult healthcare system, their actual transition or transfer experience if they were at that age, and then their opinion on care received during pediatric compared to adult years. So there was a total of 58 responses that were recorded, and they were separated into Group A and to Group B. Group A were patients between the ages of 12 and 17, and Group B were patients 18 years and older. And then most of these patients that were enrolled in this study did have severe epilepsy and comorbidities. 43% were having daily or weekly seizures, 45% being on more than 3 or more anti-seizure medications, and 74% having intellectual disability, and 22% having autism spectrum disease. So that kind of gives you the demographics of these patients. And then this was just, again, a breakdown of the demographics. So in this particular study, they did have a high population of Dravet syndrome, which is probably not reflected in kind of everyday life, but 27% of the patients had, 27 had Dravet, Lennox-Gastaut, we have Doe syndrome, Rett syndrome, PCDH19, genetic or chromosomal changes make up almost like 50% of those patients. And then again, temporal lobe epilepsy, other genetic generalized epilepsy, birth injuries, infectious causes, trauma. So these are all the patients that we see and will go to transition clinic or through transition process. So a good representation of patients that we see in the pediatric clinic. So the results were that all the patients in Group A still lived at home, while 81% of the Group B patients, 18 and older, lived at home. So still the majority of patients requiring assistance in the home and having caregivers most likely. 10 patients, which was about 17%, were still having daily seizures in the previous year. 26% were having weekly seizures, 36% between monthly and yearly, and just 21% reported no seizures in the past year. So these are patients with an active epilepsy. And then in addition to epilepsy, they also had significant comorbidities, kind of some that we talked about, 74 having intellectual disability, behavior disturbances in 16%, depression in 12%, insomnia in 12%, and then ADHD in 11%. So keeping that in mind, that not only do they potentially have to see epilepsy providers, but maybe seeing other providers for other comorbidities that will also need help when transitioning care. So in Group A, after looking at the results of their survey, so none of the 17-year-old patients reported being spoken to about transition of care. And 50% of the Group A was ages 16 to 17. So that says that we're not talking about it, especially in the age group that we should start talking about it. 72% or 23 responses of Group A reported never having a discussion about transition of care. So again, 12 to 17 years of age, 72% have never been talked to about it. Of the total 9 in that group that did have a discussion, only 5 of them reported being spoken to about it in detail, and only 1 time. And then typically they said the patients at which this had been brought up was 14 to 16 years old for 3 patients, 12 to 14 for 5 patients, and 1 patient at less than 12 years old. So it shows you that we're not very good about talking transition of care to patients, and then we might be doing it a little bit too late, which we'll go into. And then caregivers and patients with developmental disabilities reported less time to discuss important things during the transfer of care. And as you can see, we'll show you, they have a lot more comorbidities that may need addressing. In our Group B patients, again, 18 years and older, this was a total of 26 patients. 27% were still being followed by the pediatric neurologist, 3 of them with Dravet syndrome. 18 of those patients were followed by an adult neurologist, so had potentially successfully transferred. And then 1 patient was reported being just seen at emergency room physicians for their epilepsy care. So this was an 18-year-old female on 2 anti-seizure medications, does not have a primary neurologist, just goes to the ER whenever they need to. When they asked these patients in the Group B, the 18 and older, had they ever heard about the transition or transfer process, only 35% of patients said they had never heard of it. 16 patients heard between ages of 16 and 18, and 1 patient after the age of 18. So again, the majority of these patients are hearing this between 16 and 18 years of age, while 35% never heard of it. And these people are potentially patients that have already been transferred out of our system. 11 out of 27 patients and parents knew the name of their current provider, so a lot of work to be done there. And then 4 patients and parents reported the transition of care only occurred 3 months in advance to the actual transfer. So it was very quick. And if you think about the majority of these patients, a lot of the diagnoses were patients that have been probably seen since the early infancy age, and we transitioned their 18 years of care in 3 months. So quite quick. And then one patient reported feeling accompanied during the transition process. Only one patient in 26 patients felt like their transition process went well. So I think that's pretty profound when you think about it. They also asked the patients, Group A and Group B, what they had access to. Group A is listed here in the yellow, and then Group B Group A was the 12 to 17, that's in the red, and Group B was the adult patients, that's yellow. And so what they had access to in percentage-wise. And the statistically significant differences were patients saying that they had less access to psychology, dietitian, and speech therapists. And you can see quite a profound difference between those, where 64% of patients in the pediatric system had access to a psychologist, only 12%. So those patients may not be getting all the care that they need for their comorbidities and ongoing care needs. So thinking about that during the transition process is how do we set them up for seeing other providers? Are we in a resource-rich area that we can get them set up with other providers such as speech therapy, psychologists, or is this something that they may not have access to, which could be very difficult for these families? And then again, asking the relationship with their healthcare team. So this one was actually a little more positive. I think both the adult patients and the pediatric years patients felt like they had sufficient time during their visits. The adult years, they felt that they had more autonomy regarding their care. So adult providers are doing very well at allowing patients to make those decisions. Pediatric years were a little bit better at making people feel like help was readily available. Both adult and pediatric patients said that they could trust their doctor and they felt understood by their doctor. So we are doing things well in some cases, and then we have always some room to go in terms of our transition process. And then they also asked these patients what they felt we've done well in terms of our education. So the highest proportion of patients thought there was enough time discussed on driving. About 54% said it was sufficient. Pregnancy, about 29%, which I would say is probably not high, but still. And then birth control and anti-seizure medication interactions, about 39% said that we did do well at education on those things. And then asking the parents or caregivers with intellectual disabilities, only 16%, 12%, and 24% of caregivers thought that we had given enough time to discussing special education options, housing, need for power of attorney. So we are not doing very well in providing patients that kind of education during the transition process. And kind of going into thinking again, how can we do better at that for our patients? These family and patient experiences, not only in this study, but in many of the studies that I read, kind of the overall consensus is that patients and caregivers report following challenges for transition of care. Navigating a new system or being cared for by a new doctor is very scary. Not knowing how that may change, especially if you've gotten used to a system, especially with our care teams, being able to have access to us is going to potentially change when you go to an adult provider. Is it so easy as to send a message through SCM or call the office and speak with nursing? That's pretty scary for those patients. Worrying about the coming changes. Transfers were not smooth and adult care is less integrated. Parental role changes was a fear for many patient or parents, now giving that autonomy potentially to adults. And then our patients with intellectual disabilities, caregivers reported feeling a stressful process coordinating all new contacts of care and adult care. And actually in this group, this was from the study that we just talked about recently, they thought that epilepsy was only a minor part of the process. And actually the neurodevelopmental issues were often the primary concern. So when you step back and think about these patients who are going through the transition process, you can set them up with an epilepsy provider, but it may be on those parents to find a new speech therapist, new physical therapist, new psychologist, all these different things that these parents have to think about and coordinate is quite overwhelming. And so how can we best help them? This was another study. This is a transition, again, from pediatric to adult care in epilepsy, a qualitative study in adolescent experiences. This was a study back in 2024, so pretty recently. This was a cross-sectional observation study that did interviews with young people with epilepsy ages 16 to 22, a total of 37 patients. They interviewed them prior to, after their transfer to adult care, and then also interviewed their primary caregivers if they had intellectual disability, and then kind of took in their experiences and expectations on transition of care and adult medical care. So they kind of interviewed them, and these are kind of some of the sub-themes that patients reported. So on the left-hand side, this was the themes prior to transition of care for patients without intellectual disability, ages 16 to 17. So a lot of the things that there was no explicit plan or process in place, kind of practical uncertainties, and we'll see what happens. A lot of them had fear that the coming transfer was worrisome. They felt very secure in the pediatric group, general anxiety about the future and potentially managing it on their own, making many changes happening quickly, and then making other transitions will make it complex. Again, if you're having to potentially transfer other providers at the same time. Other uncertainties, will my epilepsy continue? What should be my living arrangement, especially kids who might be going off to college? Do they need to stay go to a school near their home so that they can live at home? Are they safe to live in the dorms with a roommate? Things like that is very uncertain for these patients. Another theme that I thought was interesting is epilepsy is not a big thing. A lot of these patients thought it was not a big deal, not a big part of my life. Good thing is they don't feel stigma or negative attitudes, and transition is not a big deal for me. Whether that's a positive or a negative, I think it can be taken either way. Changing parental roles, the patients felt that they wanted to take more responsibility, and then also that they felt safe with their parents. And then also thinking about epilepsy and how it impacts our psychological well-being, lack of support and difficulties in school, especially thinking again, if they're going off to college, how are they going to get supported in school? What kind of paperwork do they need? A lot to think about, things that have probably been handled by parents up until this point. And then again, on the right-hand side, now we're talking about, again, prior to transfer, 16 to 17-year-olds, but this was the thoughts of the primary caregivers for patients with intellectual disability. So again, no explicit plan or process was another theme. Have not thought about it, no communication or information about it yet from health professionals. So 16 to 17 years of age, have not heard about it or have no plan. They felt worrying about the coming transfer. They've heard of negative experiences in the adult care, fear that adult services are not designed for people with a young developmental age, having to retell a child's history again, and they're satisfied in the pediatric care system. Did have there is hope for the future that new providers give a new outlook on the patient as a new second opinion. We're hoping that the epilepsy will be gone before they have to go through the transfer process. And then it's the parents who make the transfer, not the patients. So they have to make new health contacts. They have to potentially be the primary caregiver in those adults' care. So a lot of things to think about for them. And then our child won't be a, quote, adult due to intellectual disease. So healthcare staff still need to listen to the caregivers, and then reminding that they're young, special people. So very different worries and thoughts between patients and caregivers at this age prior to transfer. And then again, they interviewed them after the transfer. So on the left-hand side, this is our patients without intellectual disability, now aged 18 to 22, who have gone through the transfer process. Again, it was no explicit plan or process. It was mentioned, but only briefly, and some of them also felt there was a gap between their pediatric and adult care. So potentially not doing a good job of supporting our patients through that process. Having to take more responsibility in adult care. That support system doesn't automatically follow like it may in the pediatric system. Some thought that it was more responsibility was good for them, and it was easier to talk about personal issues in the adult provider clinics. The pediatric care was comfortable but paternalistic, some childish clinics, but they felt like less frequent and less personal contacts on the adult side. Again, the epilepsy not being a big thing was still a theme for these patients, not really a big deal or a big part of my life. And then epilepsy still impacting psychological well-being, impact on school is still a thought and process for these patients, and then the impact of anti-seizure medications. And then on the right-hand side, now they were interviewing the patients and caregivers with adolescents who have intellectual disability after their transfer, age 18 to 22. The themes were, it was better in child services. The pediatric provider saw the person as an individual, had a closer relationship with staff in the pediatric services, and thinking about how those patients, again, may have been with us since birth, and that's 18 years of close relationships that they have established with our group. They felt like the fragmentation in adult services, the care was less integrated. Who sees the whole picture, not only addressing epilepsy, but addressing those comorbidities. A lack of understanding of child's conditions in the adult services, not understanding the child's condition, rare epilepsy or intellectual diseases, having to explain the history all over again, and then adult hospital environments not suitable with patients for intellectual disability. Also thinking that transition process in healthcare was not smooth. There was a care gap, uncertain about information exchange. Did everything go, do they have all the information at the adult clinic? Did it come from the pediatric clinic in a well succinct manner? And then difficult access to adult neurodisability services. So what kind of resources do they have, and having to think about that. And then again, support for caregivers and coordination needed for those providers. So very, again, different themes for each type of group, before and after. And this is just kind of a schematic of just summarizing that. So before and after, going from left and right, and then the patients with intellectual disability on the top and normal intellectual ability on the bottom, and kind of how their thought processes and themes have changed before and after the transfer process. But I kind of just want to point out in the very middle, it says no plan or process. So that was a theme throughout both interviews, and that's where we can potentially make the most impact, is having a plan or having a process laid out for our patients. So where do we go next in helping our patients do better at transition? So the content of transition for those with normal intellect differs from those with intellectual disability. There are successful transfer programs. They eventually need to rely on several adult physicians, nurses, and other key healthcare providers, and use novel approaches to complex care. So there isn't a standard all-for-one transition program, but in order to address kind of the things that patients want and need, that's what you would be hoping to have in a successful clinic. And then how do we implement these programs that are helpful for our patients and family, but also acknowledge the limitations for us as providers, such as cost, time limitations, access to adult providers with confidence in treatment of pediatric epilepsy patient problems. So having the resources in order to have a potential transfer clinic or transfer program. So things to consider in terms of transition. So in general, the following factors appear to positively influence the transition process: having a multidisciplinary care team, again, to address those comorbidities, continuity of care, minimizing any gaps in care, a central coordinator that can help with the pediatric and adult establishing care providers, education, telling the patients about it, talking about it early, and then patient-centered communication. And like I said, there's no currently used transition model. There's no right way that's been validated, and people have different ideas. And we'll talk about some models that have been approached. But this remains an area of interest and exploration for all of us as providers, to how do we do this best. Transition programs themselves that are established between pediatric and adult providers are not widely used even in high income countries, and nearly absent in low to middle income countries. And that also being said is that the visits are not going to be standardized, which makes it kind of difficult to have a quote standard transition clinic. So with children with normal intellectual function, with or without other comorbidities, the goal is always independence and expected to take full responsibility when they become adults. Versus children with intellectual disability, maybe the needs are clarification for the responsible party, addressing other comorbidities, support services are not always standardized and need to be addressed on an individual basis. So those are some limitations that we have in creating a kind of standard process. And this is a current study that's ongoing at the ILAE. This is for patients, and so I just wanted to put this out here. This is a questionnaire. So if you're a healthcare provider that cares for patients with epilepsy or seizures, you may be eligible to participate. It's just kind of seeing our opinions on transitions and the challenges you face while transferring your patients from pediatric to adult care. So if you have a minute, could be useful for us to better understand how we can help our patients. So this is an example transition clinic model process. This is from Nationwide Children's Hospital and the Ohio State University Epilepsy Transition Program. Again, this is just a model that they created. They started this model, starting the transition process in education around 14 years of age. At every visit, there's something called the TRAC, which is the Transition Readiness Assessment Questionnaire that was sent yearly in my chart, and we'll go over kind of what that is. And then kind of through each year discussing different things. Again, this is standardized. You may have to address other comorbidities, especially with patients for intellectual disability, so it can't apply to everyone, but this was kind of the major sub-themes. So the 14-year-old visit discussing transition education information was provided at each appointment, and then assessing if any multidisciplinary providers needed to be consulted and have education for that longevity of transition. Again, at the 16 years of age, again, they're filling out that transition readiness assessment questionnaire, and then driving decisions was a particular tool that they were using to assess patients' readiness to drive. Same sub-themes were discussed at age 16. Then at the age 17, they had their specific transition and transfer clinic referral and appointment. So this was a specific clinic that was set up, which we'll talk about how they did it for the patients in this age group. They basically had the pediatric epileptologist and an adult fellow, epilepsy fellow from the Ohio State University Hospital have a clinic appointment together, and the Ohio State University adult epilepsy fellow would kind of do the consultation. The pediatric epilepsy provider was just kind of on the side, sitting there answering questions if available, and this was performed in conjunction together. And then afterwards, they made the appointment for the adult care provider at that same clinic day. So at the time that they're having a transfer clinic appointment, they're already setting up appointments with the adult health care system at that appointment. So there should not be a gap in care. And then again, following up with the adult in 3 to 6 months. The timing was based on the recommendations of the adult provider. What was interesting, and we'll talk about this, but the fellow who did the transition clinic was not the same provider that saw them at the adult follow-up visit. So they kind of did almost 2 transfers. The adult provider was taking all the information from the pediatric hospital and then transferring it again to another adult provider. So this was kind of their system, but just thinking about that too, that's almost kind of like 2 transfers. So these were kind of the outcomes. This was in 2019, 2020. So they had pretty low enrollment. So just kind of keeping that in mind. Overall had 56 patients that went through the transition process. When you're looking at the epilepsy diagnoses, these were not like randomized whether to transition or not. It was just like 2019, they didn't have the clinic. 2020, they did have the clinic. And it just happened to be that more patients that went through transition clinic had more pharmacoresistant epilepsies like Dravet syndromes, Lennox-Gastaut, are genetic generalized epilepsies, and patients with intellectual disease. But I just wanted to point out kind of some of the demographics again of our patients that are going through the transition process. And then this was the long-term outcome on the bottom right-hand corner. So successfully transferred to Ohio State University, a total 80% did, but much higher in the patients that went through the transition clinic. 91% of those all were successfully transferred, while 65% who did not go through the transition clinic, while they did eventually transfer, was definitely not in the same time range. If you can see below on the next one, that 64% of patients in the transition clinic followed up within 6 months versus only 26% of patients in the non-transition clinic group followed up within 6 months. And then also wanting to point out the loss to follow-up or outside provider was much higher in the non-transition clinic group. 35% of those patients were lost to follow-up or went to see an outside provider versus the 9% of those patients who went to the transition clinic. So, do these transition clinics work? Are they helpful? I actually looked to see if this transition clinic was still in existence, which we'll kind of talk about it, but I don't know if this transition clinic still is in process based on kind of searching through their website. I saw this study and when they were doing it, but transition clinics are not always easy, and kind of going into talking about what they had difficulty with, which can also be applied to any transition programs. So resources, are adult and pediatric care providers in the same region? Is there support staff available? Are there adult providers with interests and skills to care for complex epilepsy patients within your region? So that is a challenge to creating a successful transition program. Managing schedules between pediatric and adult providers, as well as support staff. Could it be a specialty clinic day? Would you have enough referrals to make it a specialty clinic day? It's difficult. Reimbursement, who gets paid? There is an encounter code for pediatric to adult transition, but obviously only one provider can bill. And so going back to the previous model that Ohio State had used, again, they had a pediatric epilepsy attending and an adult fellow. So the pediatric epilepsy attending was the one billing for that transition clinic visit, because you can't have both. If you're using a fellow-driven program, there's high turnover of providers each year. If it's a 1-year versus a 2-year fellowship, you would need consistent partnership with adult fellowships to align schedules to allow fellows to come over to potentially the pediatric or to the adult side to provide that transition. And then there, of course, there's always disagreements on transition timeline. Everybody doesn't fit into the same model. The ILAE recommends starting transition discussions at age 12, but when that transition should actually occur is different for each patient and different for their needs. So there's no standard, and so that kind of, for other providers, would probably maybe limit the referrals to the transition clinic if only, some 18-year-olds, some 21-year-olds, things like that. So something to think about in challenges. And then this was another study of another attempted fellow-driven transition clinic. This was out of Boston Children's. And this is discussing their perspective and challenges on sustaining a transfer clinic. So again, this was driven initially by fellows that allowed the launch of the clinic while circumventing that billing issue with only one provider being able to bill during that transition clinic by having both adult and pediatric epileptologists attend the clinic appointment. So then in this case, they did the same thing. A pediatric epileptologist was seeing the patients with an adult epilepsy fellow. So the fellow would take notes and then transition them to another provider in the adult clinic. So they did not stay with a fellow in their own clinic. So kind of, again, while it does help with the billing issue, does not necessarily help with the longevity of the patients. They meet this adult epilepsy fellow, and then have to meet another adult epileptologist. So kind of telling their story again. This model was in effect for 2.5 years. During the first 2 years, again, we're staffed by 2 consecutive adult epilepsy fellows, and then eventually it was handed over to a transition care neurologist who had appointments both at the pediatric hospital and at the adult hospital. So the salary was split between the 2 hospitals. However, only over a course of 2.5 years, they were only able to transition 8 patients during that period. And despite creating an amazing position, allowing a provider to see both adult and pediatric patients, they did not get the referrals, and it continued to falter. And then after about 6 to 8 months, the transition clinic was dissolved. So only lasted about 2.5 years. And they noted the lack of defined roles and support staff as being a limitation, like who prepared the medical records, especially once it was handed over to the provider who was seeing 50-50. Previously, all the fellows were making the EMR, adding in all the information, taking the medical records, and getting them scanned in. And so whether the new provider was doing that, that was kind of some a process that they found was difficult. There was a high turnover of fellows, a lack of standardization of practice, which led to some of the failures in establishing the clinic. Again, they said that some providers noted not feeling comfortable starting the transition process around the same age. So that limited how many patients that they could get through that transfer clinic. So this is probably a more realistic example of how difficult it is to have a transition clinic. Outside of kind of managing a transition clinic, how can we, if we don't have a transition clinic or established program, how can we best set up our patients? One particular form that I think might be helpful to integrate into our everyday practice is something called the Epi-Track. So this was developed in Ann Arbor, Michigan. It's based off that transition readiness assessment questionnaire. It's a valid and reliable tool for assessing transition readiness in adolescents and young adults with epilepsy and without intellectual disability. So this is just for those patients. And it helps providers and patients understand their knowledge and strengths and gaps in managing their own care. So this is kind of an example of what the Epi-Track looks like. Some of the questions, again, it's, it goes from left to right. I don't know how, I don't, but I want to learn. I'm in learning, but I am learning to do this. I've started doing this, and I've always wanted to do this. And then just looking at the different themes of this readiness assessment, managing our medications. Can you name seizure medications? Can you name them correctly? Do you know how to fill a prescription? Do you know how to reorder medications? Appointment keeping. Have you ever called the doctor's office to make an appointment? Do you have follow-up or referrals for tests, checkups, labs? Do you know how to schedule those? Do you know how to apply for health insurance if you lose your current healthcare coverage? And then do you know how to manage money, like checking in debit cards, tracking our health issues? Can you explain what type of seizures you have, especially important if you're going to an adult provider and you can't tell them what the name of your diagnosis or what type of seizures you are, kind of limits the care that they can receive. Can you explain why you have epilepsy? Do you know what to do if you're going to have a seizure? I think very important. Other things, talking with providers. Do you tell your doctor or nurse how you're feeling? Do you feel your questions are answered if you're being asked them by the doctor, nurse, or clinic staff? And then managing daily activities. Do you know how to feed yourself and keep your house clean? And do you know how to explain how epilepsy affects school or having a job? Can you explain activities that you are not allowed to do, such as driving? Can you describe how long you have to be seizure-free before you're allowed to drive a car? So I think asking these questions is super important. Obviously, you probably can't address all of these every single visit, but assessing these patients' needs and then trying to tailor your education at every visit to addressing some of that might be the most important if you can. And hopefully if we start at age 12, let's say, for some of our patients, by 18 or 21, when they're ready to transition, hopefully we're having answers more on the right-hand side and less on the left-hand side where they don't know how to do those things, which I think was shown in the earlier slides is that still a lot of our patients are kind of towards the left. They don't know how to explain their epilepsy and explain their medications and how it works. And so I think it's important for both us as providers to tailor education, but also for parents, for patients with epilepsy, what they need to do in order to get ready for the transition process and how can they better be educated. There's also other tools like education programs. This is bmedwise.org. This provides information on medications, brand names, how to read a medicine label, and how to establish a living will or guardianship. And so some of those sub-themes were addressed on the EpiTrack. So if you see that those things need to be addressed, that could be something that you could refer your patient to in order to hopefully help educate them. Raising Special Kids was here in Arizona. They have training workshops, one-on-one consultations in order, let's say if you're a patient or a caregiver with a patient with intellectual disabilities, how to establish guardianship. They're able to help with that. There's also parent-to-parent support for, like, let's say a patient with a new diagnosis. They can support kind of a mentor, match you with a mentor parent who might also have that a family member with that same diagnosis. And then the Epilepsy Services Foundation, this had a really nice website. It provided a checklist of skills to master prior to transition. So this can kind of be a self-assessment again for patients. It provided an important list of documents to have to bring to your first appointment, including getting your records ready, having a list of your medications and your current dosing, the name of your diagnosis, being able to describe potentially your lab results or your MRI results. And so that's a nice kind of checklist if that's how, might be helpful to our patients. And then there's also several apps that you can also encourage your patients in adolescence to use, like MedMinder, MedSafe, or a Pill Reminder, so that we can encourage good compliance with their medication. Parents can, have them encourage them to download the local pharmacy app on their patients' phones if they have them. Have them practice ordering refills, looking for prices of medications like GoodRx, things like that. Teach them how to be self-sufficient if able. And then also setting up the patient portal for transitioning patient to practice navigating health records and results. So a lot of our parents have patient portal access. Let's encourage them to show the patient how to use it, how to get their records, who to call when needing their records. And so trying to establish a little independence as well. Medic alert jewelry, especially if they're going to be out of the home. And then this EpiHab is an organization that provides employment opportunities for those with epilepsy. And that's out of Dr. Williams' End of Visit. So another great resource that is provided. So I think this is my resources, but I just want to say thank you and just hope that even we can if we don't have a established transition program, things that we can do better for our patients to help them be ready during that transition process. And then maybe someday, if we're lucky, we can have a transition program, but taking baby steps into making care a little more coordinated, seamless, and having our patients feel supported is really important. So thank you very much. And I'll see if there's any questions in the chat group. I'm sorry if I missed anything.
Hey, Rebecca, I actually have a comment. So this is a fantastic talk. Transition care, first of all, this is an incredibly comprehensive talk too. I was really impressed with the amount of work you put into this. Very, very good. It's obvious that you did a lot of work for this talk, and I certainly appreciate it. We face the same issue in pediatric neurosurgery, okay? And the challenges are immense. Like, so there are expertise related challenges, which are there adult providers with the expertise to manage congenital conditions, right? So that's an issue. Then there's an interest problem, which is, are there adult providers not only who have expertise in managing congenital issues, but are interested in doing it in their practice? And the answer to that one, unfortunately, is tragic, but unfortunately, is a resounding no. And then you have all the logistical administrative challenges, right? So like, I came from the University of Washington, where the neurosurgeons there were the same neurosurgeons in the university practice that took care of adults. And there we were able to cobble together a reasonable transition of care, which is no different than what Ohio State and Nationwide are doing, right? But they have the benefit of having a bunch of specialists that are linked to them through faculty appointment, right? So they can like pressure each other and like doing this. But when you're a standalone children's hospital and you're looking for willing partners in the region who want to take these kids, it's challenging to convince them that this is a worthwhile endeavor from a financial perspective, as well as from like an interest and expertise perspective. That said, all of that said, this is something we can do. It's a tremendous amount of work. And so I
Yeah.
really appreciate you, talking about this.
Yeah, thank you. I agree. I think that's it's immense what we can potentially do, but a lot of work. And then Dr. Chapman said there's a relatively new epilepsy transition clinic at Mayo, but insurance is a likely issue. And then exact same challenges that we have with our cerebral palsy patients. So yes, this is a challenge in all a lot of chronic illnesses, not just to epilepsy, but I think it points out kind of where we are, and maybe these challenges are the same sub themes, and education can be applied to lots of different types of patients. And then Dr. Lewis said, do our nurses have a written copy of the Epilepsy Foundation checklist for transition? I don't think so. This was just something that I particularly found, but I think it would be a reasonable resource to provide to patients to help them, start checking things off to see how ready they are. And then we don't particularly, it's not part of our regimen to use the EpiTrack form, but again, that can be something that if you want to integrate into your practice and start assessing those needs, I think it would be wonderful if we started doing it for all of our 14, 12 and older patients on a yearly assessment. That would probably need something to be integrated into the electronic medical record, but something that we can do to start.
Hi there, Becca. Wonderful, wonderful talk. Thank you so much.
Yeah.
As you know, and as we talked about, this is something that I've been trying to work on for a long time here at Phoenix Children's, and looked at lots of different things. And you really perfectly showed all of the challenges that, have come up in the process. A few things that we have done and we've looked into. So Child Neurology Foundation actually has a transition booklet for all child neurology. So it's not specific to epilepsy, but is a 14-page document. So it's a little bit cumbersome. So what we have done is we basically brought that down to a single-page document of transition. So all the pertinent information we felt was necessary. And we started to implement it. I was looking for feedback from some of our adult providers on whether or not it was helpful to them. We never really heard back. And so it was a bit of a process to do. So I don't think it's been continued. I certainly haven't continued doing it. I don't know if any of the other epileptologists have, but if it was a positive system, we were hoping we could integrate it into the medical record. So that was our most recent approach. Like I said, I've tried lots of different approaches, including similar ones with having, dual providers present and things like that. But it really, truly is a challenge for our patients. But I think the most important thing to take away is discussion with families early on. And really outlining for families what this looks like. I think that is appreciated not only by our, intellectually normal kids and, understanding what to expect, but also in our patients who have severe intellectual disabilities, so that the families can be on board with what the transition is going to look like and what they can expect. Because one thing I will tell you is they don't like surprises. They don't like, abrupt changes. And so if they're hearing this conversation for years, it really goes a long way.
Yeah, absolutely. Completely agree. Thank you, Dr. Fox. And yes, Sarah, I agree. A nurse practitioner would be a great benefit in the transition efforts. Again, lots of barriers, but definitely would be a wonderful addition to it. Well, thank you all very much. Are there any other questions? All right. Well, have a great Monday. Thank you.